chairs, dear audience, good afternoon everyone. It's a greatest pleasure to be here and present the progress of my PhD studies from the past 2 years. My name is Edina Tari and I'm a second year gastroenterology resident and a second year PhD student. My supervisor is Bálint Erős and my SMS is Anett Rand. My vision is to improve patient care in acute gastrointestinal diseases, and my mission is to conduct high quality researches in the same population. Today I would like to present you two of my ongoing projects. The first project is a systematic review and meta-analysis about how the morphology of the major papilla affect bile-duct cannulation outcomes and adverse events. ERCP is the most common therapeutic procedure for pancreatobiliary disorders. However, how to best achieve a safe and effective bile-duct cannulation is still debated. The incidence of adverse events is still high. For example, post-ERCP pancreatitis, which is the most common adverse events of the ERCP procedure, has an incidence rate of almost 10% with a mortality rate of almost 1%. Endoscopists doing ERCP routinely recognize a difference in the macroscopic appearance of the papilla. This has led to a conclusion that certain appearances are more difficult to cannulate and therefore more prone to adverse events. The first validated classification system of the morphology of the papilla was published by a Scandinavian research group in 2019. They also published a prospective cohort study, and they found that indeed certain appearances were more difficult to cannulate, and in these appearances the incidence of adverse events was higher compared to the other papilla type. We aim to determine how the morphology of the major papilla affect ERCP outcomes and adverse events. Our clinical question was that how does the morphology of the papilla affect bile-duct cannulation outcomes and adverse events, and we used the COCO-POP framework. Our conditions were difficult cannulation, cannulation failure, cannulation attempts and cannulation times, and the rate of the adverse events in the context of the papilla morphology in adult patients undergoing ERCP with a native papilla. And we hypothesized that certain appearances can predict a more difficult cannulation and a higher rate of adverse events. We conducted our systematic search in 3 databases in 2022 September with the following search key. And we could identify almost 7,000 articles, and in the end, 36 were eligible for full text selection, and to the systematic review part, we could include 17 articles, and 14 were eligible to the meta-analytical calculations. For the outcome measure, we use pooled event rate with a 95% confidence intervals, and you can see that the meta-analysis were possible in 4 outcomes. In the other 4 outcomes, they went to the systematic review part of the article. So today I would like to show you 2 of my forest plot. In this forest plot, you can see the pooled event rate of difficult cannulation. In the plot itself, you can see the pooled event rate for the different papilla types below each other. This question is clinically relevant because the higher the rate of difficult cannulation, the higher the rate of developing the different adverse events. And you can say that in this calculation, the heterogeneity was high. It could be due to the fact that there were some difference in the definition used for difficult cannulation. And the main message is the forest plot that in type 1 papilla, the rate of difficult cannulation was significantly lower compared to the other papilla types. However, the p-value was not itself statistically significant, but it could refer to a higher tendency. And this is, in my opinion, important because as I can interpret, maybe trainees should start with type 1 papilla when they start the ERCP training. So in the second forest plot, you can see the pooled event rate of post-ERCP pancreatitis. The structure of the forest plot is exactly the same. You can see the pooled event rate for the different papilla types below each other. And you can see that in this case, total homogeneity was observed. And this question is important because, as I said, post-ERCP pancreatitis is the most common adverse event of the ERCP procedure. And the main message of the forest plot is that in type 2 papilla, the pooled event rate was significant. Pooled event rate of post-ERCP pancreatitis was significantly higher compared to the other 3 papilla types, and you can also see that this was actually a statistically significant result. And I would interpret it the following way, that maybe these patients, you should care more carefully, following them for defining post-ERCP pancreatitis after the ERCP procedure in the board. There were many strengths of our meta-analysis. For example, it was a comprehensive review with a rigorous methodology, and most studies carried a low risk of bias, and we could not detect any publication bias. However, there were some limitations. As I said, there were some difference in the clinical definition, and because we included retrospective analysis and also high quality but some abstract, the evidence were low or very low in the most calculations. In conclusion, to differentiate between the papilla types is clinically relevant because, as I said, certain morphologies can predict a higher rate of difficult cannulation and a higher rate of adverse events. Our implication for practice is to promote to use a unified classification system like the Haraldson, because it would increase transparency and also make possible researches, make further researches possible. And as I said, maybe trainees should start their practice with the type 1 papilla. And I'm happy and proud to say that our article was published in the Van journal this March. And let me quickly talk about my second project, which is about the early resuscitation of the hemodynamically unstable gastrointestinally bleeding patients. This is a protocol and actually also the feasibility trial for an RCT. Acute gastrointestinal bleeding is a potentially life-threatening event, often requiring emergency medical care. When involved, patients will develop hemodynamic instability associated with higher rebleeding and mortality care. However, the guidelines are lacking specific recommendations about the early resuscitation of this population. We conducted a systematic search to try to identify articles about fluid use and also about vasopressor use in this population, and we could identify only one small RCT with 51 patients. They included a very fair population, patients with acute gastrointestinal bleeding requiring actually ICU care. And in the intervention arm, these patients received the fluid therapy with dopamine, a limited fluid actually, and in the arm B, the patients received the conventional fluid resuscitation therapy. And as you can see, that the resuscitation time was significantly lower in the arm A. Those patients were, as I said, who received a limited amount of fluid combined with dopamine. And our plan is to conduct an open-label 2-arm RCT with a superiority study design. We would like to include the hemodynamically unstable patient with acute gastrointestinal bleeding. And in the intervention arm, these patients will receive fluid therapy combined with vasopressor compared to only the conventional fluid resuscitation therapy. And our primary outcome will be the resuscitation time. And for the start, we would like to include 15 patients to both arms of the RCT. And I'm happy to say that I presented my first project in many international and also in national conferences. And I'm also more happy to say that I have other 2 articles as a first author published, and I have 2 others ongoing projects which unfortunately I cannot present you today because the lack of time. In summary, my first project is already published and finished, and in July, 1st of July, we will start the feasibility trial with the 15 patient for the RCT. And thank you for your attention. And let me finish with this quote from Nikola Tesla: "Let the future tell the truth and evaluate each one according to his work and accomplishments. The present is theirs, the future for which I have really worked is mine." Thank you again.
Thank you very much for the presentations and for congratulations for the accepted paper. Now this topic is open for discussion. Any question from the floor?
I would like to ask you about post-ERCP pancreatitis. How can you define this? Thank you.
Yeah, and thank you for your question. Most studies, they find it as the Atlanta classification, and the way we usually define post-ERCP pancreatitis, like the rule, like 2 out of 3, like some epigastric pain, the amylase or lipase level 3 times higher than normal, and like the signs of pancreatitis on some imaging. But some definition used they didn't define post-ERCP pancreatitis, and some others also use like kind of definitions like the similar as cotton, which is like the epigastric pain, causing like longer hospital stay with at least 2 days, and also the higher amylase or lipase level. Thank you.
Yes?
Thank you for your presentation. My question is that in your daily practice, do you use rectal NSAIDs for preventing post-ERCP pancreatitis, or are there any newer drugs or interventions which should prevent the post-ERCP pancreatitis? Thank you.
Thank you for your question. In my ward, we use every patient, we administer ringer lactate for every patient, and also rectal NSAID before the ERCP procedure. Those are the things that we use.
Regarding the first project, were the investigators at the same level of experience in all of the studies?
Yeah. Actually, in some studies which investigated the level of the expertise of the endoscopists, they were not in the same level, but they found these studies that it actually doesn't influence the success of the ERCP or rate or the rate of the adverse events.
And probably the so-called high-risk group for PEP could also consider to include type 2 papilla. Maybe. Yeah. And I had another question regarding the second project. What is this new score? I am not aware of that. Could you tell me something about it?
Yeah, it's the National Early Warning Score. We will use the NEWS 2 score actually because it's superior, because it assesses the patients with COPD differently. And the new score includes the vital parameters, actually, the systolic blood pressure, the consciousness, the temperature, the heart rate, the need for oxygen supplementation, and I think those are, and maybe, And based on that, you will have a score, and you can, it's assessing the early warning score for the patients. Is for for patients admitting for acute diseases to have a guess.
And you want to assess whether you have or you can cessate the arterial, so the circular resuscitation sooner, and it results in the complete resolution of the instability sooner than compared to normal fluid.
Yeah, exactly. We will use the NEWS2 score combined with arterial blood gas test with the lactate level and the basal sex level.
I see. And then you will slowly start to reduce the level of resuscitation of the epinephrine, and then see whether it is enough or it could be stopped or not.
Yes.
Good. Thank you.
Thank you.
Thank you. Thank you for the talk. I have a question regarding your first topic. I saw you highlighted some I squared equals 0%. Can you tell me what's 0 in this case exactly?
It means that it was total homogeneity between the studies, because it was 0. If it's higher, then it means higher heterogeneity between the studies. 0 means that there were not significant heterogeneity among the studies, if I'm correct.
Thank you for your presentation. I want to come back to the first study about post-ERCP pancreatitis. So, we have a couple of surgeons in the group, and there are a couple of gastroenterologists and endoscopists. And in our community, we have a discussion about caseload. So in pancreas surgery, in esophagus surgery, so you have to have a certain amount of procedures to have the license to do so. And this is a big issue in our community. So you run through the literature about the post-ERCP pancreatitis. And I was wondering why you don't have this discussion in this community. Or I'm wrong, I don't know. Is there any idea of discussing having a special caseload also in ERCPs?
Yeah, definitely. Like there is a number of cases that you have to do to be licensed. You can do it before that, but you need to be supervised by a person who like reached this license. And as I said, like in our studies, the rate of cannulation failure was not like a difference between endoscopists just starting their ERCP practice and between the specialists, but it's not the truth, I think, in general for the literature. It was just true for our studies, but of course, like the bigger expertise you have, the higher the rate for you to succeed throughout this procedure, and definitely you need a certain number to reach, but it differs between the guideline as I know, like for how many procedures do you need?
I'm interested in your opinion. So if you have the position to make a definition, to say to this gentleman, you only can do ERCPs when you do let's say 100, 200 ERCPs or so. What is your opinion?
I think
just give us a number.
100 will be perfect, but I think in reality that's too much. So maybe.
Actually, you need to do more than 200, 300 cases before you are reaching the proper competence of the cannulation, and also you need a certain caseload continuously to maintain this capacity. So there are actually quite good studies on that. So I was surprised that you said that there was no influence whether it was an expert ERCPist or a beginner, because it is contradicting what we are knowing of this. You mentioned that the difficult cannulation definition was a bit different between the studies. So what is the accepted definition of difficult biliary cannulation, and what was the difference in your papers, in your study?
Yeah, so most studies use the ESGE definition, which means that either like more than 5 minutes, or like trying more than 5 times, or going to the pancreatic duct at least 2 times. And most studies use that definition, which is the accepted. But there were studies which like excluded the part like going to the pancreatic duct. They just use like either like more than 5 minutes, or like trying more than 5 times.
Congratulations to presentation and publication. So I got a question regarding your second topic. So the efficacy outcomes are, I think, clear. My question would be regarding your safety outcomes. Which safety outcomes are you interested in?
Yeah, so it will be a pilot study, and what we will use, if the patient's NEWS2 score will be, so we will reassess the NEWS2 score in every 15 minutes. And if it will goes like above 6, these patients will be excluded, and because most probably they will need ICU care or like the normal dose of vasopressor therapy. So that will be, or of course, like if another like acute events happening, like heart attack or something throughout the resuscitation, which is like unlikely, but you can never know, that will be also be an exclusion criteria as a safety criteria.
Congratulations as well. Maybe I missed it, maybe due to late hour. What's going to be the vasopressor used in the second study which you presented? Thank you.
We will use noradrenaline, norepinephrine as a vasopressor. Thank you.
You used random effect meta-analysis. What would have happened if you used fixed effect meta-analysis? Even or especially in the case when the I-squared value was very small, zero-ish.
So if we would use fixed effect model, it would not like really include the between study heterogeneity. That's why we use random effect model.
Exactly, but if the I-square is zero, then what difference would you expect?
It would be like probably higher. Low. It couldn't be lower.
Yeah, I mean, then essentially the two would be the
the
same,
same,
because if
actually,
there is no
yeah.
heterogeneity,
It
but
cannot be like
you
minus,
answered
but the same.
that you are using a random effect because there is heterogeneity. If there is no heterogeneity, then
So it would
basically
be the same, yeah.
more or less. Yeah. Thank you.
I have one more question regarding the definition of hemodynamic instability. Because I previously published a study about hemodynamic instability in GI bleeding, and among 220 studies, almost all authors define it differently. So could you please elaborate on that?
Yeah, there was a co-author.
Yeah.
So we will define it, as I said, the combination of the NEWS2 score. It will be between the NEWS score had to be between 3 and 6. And we will combine it with the lactate level, which has to be above 2.5, or the base excess level should be below -4.
And what is that score? The NEWS score?
2.
What does it include?
That's the National Early Warning Score 2, which is that includes basically the vital parameters as like heart rate,
right.
systolic blood pressure, consciousness, and those.
All right, thank you.